My dear students, welcome. We are ready to discuss autonomic nervous system. Autonomic means works on its own. Doesn't need to go to the brain to ask for smaller orders. And it has two components. One is adrenergic system and another one is cholinergic system. What we start with is adrenergic system roughly coincides with sympathy. That's the sympathetic nervous system which comes to our help in case of emergency. And that's why you might have read it's about flight, fight and fright. What does it do in these situations? It stimulates the heart, contracts the heart to maintain the cardiac output. It produces bronchodilation so that the person can respire well. It produces vasoconstriction in the blood vessels to maintain the blood pressure. It carries out the blood supply to distant organs and leads to increase in the blood sugar by breaking down the glycogen and by converting non-sugar substances into sugar substances, what you call gluconeogenesis, and it dilates the pupils. These are the functions of the sympathetic nervous system. Sometimes you also call it as SANS, that sympathetic autonomic nervous system, and it's present in the thoracolumbar outflow from C8 to L23. The ganglia are located away from tissue innervation, and as you can see on this slide, there are enormous number of ganglia which take care of the sympathetic innervation. There are long postganglionic fibers because the ganglia are away from the tissue innervation, and it works as a single functional system or unit. The neurotransmitter at most of these places, sympathetic places, is norepinephrine. There are various second messengers which are the G protein coupled receptors, what you call GPCR. The alpha receptors, the alpha 1 receptors have got GQ proteins, and the alpha 2 receptors have got GI proteins. The beta 1 receptors work by the mechanism of the GAS proteins. You can have a look at this particular slide where you can get the various second messenger systems for alpha 1, alpha 2, beta 1 and beta 2 receptors. Let's have a look at the adrenergic transmission. The precursor for adrenergic transmission is tyrosine. The tyrosine is entering the adrenergic nerve terminal. The tyrosine enters. The tyrosine gets converted into dihydroxyphenylalanine, that's DOPA, and the enzyme working here is tyrosine hydroxylase. This particular step, tyrosine to DOPA, is a rate limiting reaction. This reaction is going to determine finally how much of the neurotransmitter is going to be secreted. Going to the next step, if you look at this slide, DOPA gets converted into dopamine with the help of the enzyme DOPA decarboxylase. Dopamine enters the granule with the help of carrier B, and after going inside gets converted into norepinephrine. In response to the impulse, the norepinephrine is released from the adrenergic nerve terminal from the presynaptic membrane in presence of calcium. And this norepinephrine which has come out acts on the adrenergic receptors, which is a postsynaptic receptor. This norepinephrine which has come out can get diffused in the synaptic cleft and can get breakdown, can undergo uptake 2 in the postsynaptic cell, or also can go inside by the mechanism of uptake 1. So that's regarding the important steps in the adrenergic transmission, and important to remember tyrosine to DOPA being the rate limiting step of this reaction. After knowing the adrenergic transmission, I'm again going to show you the steps and the enzymes so that you can remember them very well. Look at the slide. Tyrosine to DOPA is by tyrosine hydroxylase. DOPA gets converted to dopamine by L-aromatic amino acid decarboxylase. Dopamine into norepinephrine by dopamine beta hydroxylase, and then this norepinephrine could get converted into epinephrine in the adrenal medulla. So this is how you get synthesis of norepinephrine at the sympathetic nerve terminals, and in adrenal medulla you get synthesis of epinephrine. We already showed you the rate limiting step, and we already told you the release is calcium dependent. This is the breakdown of epinephrine and norepinephrine. You can again have a look at this slide and study this particular slide in details. If you look at this, it's a funny way of breakdown. If you look at it carefully, you will understand that each of the substances is undergoing breakdown with the help of two enzymes. One is MAO, that's monoamine oxidase, and the second one is COMT, that's catechol O methyl transferase. Epinephrine and norepinephrine both undergo breakdown with the help of monoamine oxidase into dihydroxymandelic acid, and then this substance is acted upon by COMT. If you go to the other way around, epinephrine and norepinephrine, both of them, they can get degraded by COMT, that's catechol O methyl transferase, as well, to form metanephrine and norepinephrine. And after this is formed, norepinephrine and metanephrine, both of them again are subjected to the breakdown by monoamine oxidase. Finally, all the pathways lead to the synthesis of 3-methoxy-4-hydroxymandelic acid, which is popularly called vanillyl mandelic acid. And if the vanillyl mandelic acid levels are more, if the VMA levels are more, it means that there's more synthesis of epinephrine and norepinephrine inside the body. Increased levels of excreted VMA in 24-hour urine is an important diagnostic test for diagnosis of pheochromocytoma. Is a tumor of adrenal medulla which intermittently secretes epinephrine and norepinephrine. Because epinephrine and norepinephrine are secreted more, you are likely to get more VMA in the urine. This forms the basis for this diagnostic test for pheochromocytoma. What are the adrenergic receptors? I'm going to tell you certain rules. If you remember these rules, you're never going to get wrong on the adrenergic drugs. What's the rule for the adrenergic receptors? Look at the slide. In general, the alpha receptor is stimulant. Henceforth, I'm going to show stimulation with the help of an upward arrow and depression or inhibition with the help of a downward arrow. So, the general rule is alpha receptor is stimulant and the beta receptor is depressant. This was fine until now, but there are some exceptions to this particular rule. Let's come to the exceptions. What are the exceptions? In the heart, it's opposite. Here, the alpha receptors become depressant and the beta receptors become stimulant. And the most predominant receptor in the heart is beta-1 receptor. So whenever you think of heart, think of beta-1 receptors. Alpha receptors are quite less in number and beta-2 receptors almost not there in the heart. So heart predominantly contains beta-1 receptor. Normally the beta receptor is supposed to be depressant, but heart being an exception, this beta-1 receptor becomes stimulant receptor. It means if you stimulate the beta-1 receptor in the heart, it's going to lead to cardiac stimulation. The second exception is the kidneys. Normally the beta receptor is supposed to be depressant, but this beta receptor in the kidney is beta-1 and it leads to secretion of renin in response to various stimuli. So the renin secretion by the kidneys is under the control of beta-1 receptors. The next exception is the gastrointestinal tract. And here you get both types of receptors, alpha and beta, and they are mostly alpha-2 and beta-2. Normal rule is alpha stimulant, beta depressant, but here alpha-2 as well as beta-2 are depressant receptors in the gastrointestinal tract. And lastly, we got to remember the central nervous system. Here you have alpha-2 adrenergic receptor, and it's an exception. Alpha receptor is supposed to be stimulant, but in the central nervous system, this alpha-2 is a depressant receptor and it's a presynaptic receptor. What do you mean by this? The meaning is, if you stimulate the alpha receptor in the CNS, which is alpha-2 receptor, because the receptor is depressant, is going to lead to decrease in the sympathetic activity. The sympathetic outflow is going to be decreased. You got to remember, even if you stimulate the alpha-2 receptor in the CNS, because the receptor itself is depressant, is going to lead to decreased peripheral sympathetic activity. So that's regarding the general rule. What I would advise you is, you make a nice chart of this particular slide and paste it in your bedroom, where you're likely to see it every day That way you remember it. And just go on coining the actions of the drugs based on the receptor, and you'll never be wrong. We next go to the distribution of receptors. Where are the receptors present? The most predominant site for alpha receptors is the peripheral blood vessels. What is peripheral blood vessels? They are the smaller blood vessels present in the skin and the mucous membranes, and most of the alpha receptors here are alpha-1 receptors. What we saw is alpha receptors are stimulant according to general rule. So when you stimulate these receptors, this blood vessel is going to get constricted and is going to lead to increase in the blood pressure. So these alpha-1 receptors are responsible for vasoconstriction and increase in the blood pressure. After the peripheral blood vessels, the next receptor site is the radial muscle of iris, which contains alpha-1 receptor, and this leads to dilation of pupil. That's mydriasis. It's radial muscle of iris. Let's understand what do you mean by this. It's radial muscle. So this is your iris and this is the radial muscle. Look at the direction of fibers which I have been drawing, and I'll also draw an arrow to make you remember that this is the direction of the fibers to contract. So what we are calling this as the radial muscle of iris. This contains alpha-1 receptor. So when you stimulate this kind of a receptor, because the fibers, muscle fibers are directed inside out, it's going to contract like this, and the pupil is going to dilate. So that's mydriasis. And because the drug is acting directly on the receptor, we call it active mydriasis. The next site is the gastrointestinal and genitourinary sphincters. Trigone, this contains alpha-1 receptor. GIT, as we just said, contains alpha-2 receptor, and the sex organ for ejaculation contains alpha receptor. Let me also include the central nervous system containing alpha-2 receptor, which I told you a few minutes ago as the exception. It's a presynaptic receptor, and when you stimulate this receptor, there's decrease in the sympathetic outflow. Let's come to the beta receptors. The first site, as we already said, beta-1 receptor in the heart, leading to stimulation of the heart, and the beta-1 receptor in the kidney, leading to renin release. Beta-2 receptors are mostly present in the smooth muscles. This includes the gastrointestinal tract, the uterine smooth muscle. This is going to lead to relaxation. The skeletal muscle blood vessels is also going to relax and dilate. The bronchial smooth muscle is also going to relax and dilate, and the detrusor is also going to relax. The meaning of this is it's a beta-2 receptor. If you remember what we just said, alpha are stimulant and beta are depressant. And do we have any of the smooth muscles in the exceptions? No. The exceptions were heart, the kidney, the GIT, and the central nervous system. We don't have any of these in the exceptions of the smooth muscle. So you have smooth muscle of uterus which gets relaxed, the bronchial smooth muscle gets relaxed, and the skeletal muscle blood vessels, they relax, meaning by vasodilation. So beta-2 receptor stimulation is going to produce mostly dilation or relaxation. The last receptor site is liver, which contains the receptor leading to glycogenolysis and the glucagon release, and this is under the control of beta receptor. Salivary secretion, which is thick and viscous in nature, is also under the control of sympathetic nervous system. There are some sympathetic drugs which are called mixed action sympathetic drugs, directly acting plus indirectly acting. Let's understand what's directly acting. When you say a directly acting drug on a receptor, it means this drug is an agonist at the receptor and is stimulating the receptor. So we have epinephrine, norepinephrine, isoprenaline, phenylephrine, methoxamine, etc. When you say indirect acting, what is the drug doing? It's not combining with the receptor, but it's increasing the release of the neurotransmitter from the adrenergic nerve terminal. We have tyramine and amphetamine as examples of indirectly acting. And there are some drugs which could act on the receptor, plus they could stimulate the release of the neurotransmitter. We would call them as direct plus indirectly acting, and that's why I'm calling them mixed action, having both the actions. And you have examples of ephedrine, dopamine, and methamphetamine are the mixed action agonist. It's very important to know that those substances which are indirectly acting or mixed acting, they lead to tachyphylaxis. I would like to suggest you to go back to the general pharmacology module where we discussed the factors modifying drug effects, and we had mentioned of tachyphylaxis. And the examples of the drugs producing tachyphylaxis was again tyramine, amphetamine, and ephedrine. As you can see on this slide, they are either indirectly acting or mixed acting. This produces tachyphylaxis if the drug is used or repeated acutely by repeated administration. Now we move on to the adrenergic agonist proper. And the adrenergic agonist, because they are going to act like sympathetic, it's called sympathomimetics, means they mimic the sympathetic nervous system. These drugs, based on structure, could be divided into catecholamines and noncatecholamines. What's this catechol? When do you call it catechol? When you have substitution of OH group at position 3 and 4 on the benzene ring, it's called a catechol nucleus. It's called a catechol structure. So catecholamines have OH substitution at position 3 and 4. Non-catecholamines do not have OH substitution at position 3 and 4. Is it important to remember this? Yes. This structure of the drug makes a difference in the properties. If you have OH substitution at position 3 and 4, if you are a catecholamine, you are comparatively less lipid soluble. If you are less lipid soluble, the oral absorption is likely to be less. So the catecholamines cannot be given by oral route of administration. Just think yourself, have you ever heard of a tablet of epinephrine or norepinephrine or dopamine? No. You cannot have tablets because these drugs are catecholamines. They are less lipid soluble and there is very poor oral absorption. So you cannot give them orally. Just as this, these drugs cannot cross the blood-brain barrier because they are less lipid soluble. I hope you remember those substances which are more lipid soluble are likely to cross the blood-brain barrier easily. They don't cross blood-brain barrier. Naturally, you don't expect any central nervous system actions or central nervous system adverse effects for the catecholamines. Let's go to the other side. The opposite column is about non-catecholamines. They don't have OH substitution at position 3 and 4. So we call them non-catecholamines, and this gives them a very important property, and that they are highly lipid soluble. Once you are highly lipid soluble, you are likely to be absorbed by oral route of administration. So you have tablets available. Look at the names of the drugs and you'll realize you have ephedrine tablets and amphetamine tablets. Because these drugs are highly lipid soluble, they get absorbed by oral route of administration. Just as this, because there is more lipid solubility, they cross the blood-brain barrier and they produce central nervous system actions as well as the adverse effects. I hope you remember amphetamine has got very important central nervous system actions. We will refer to amphetamine in our further discussion. We have 3 drugs now, epinephrine, norepinephrine, and isoprenaline to be discussed. We'll try to sort out the differences and the similarities between these 3 drugs. Epinephrine acts on alpha as well as beta receptors. Norepinephrine also acts on alpha beta both, but its actions are predominantly on the alpha receptor, which I am showing as alpha more than beta. The third drug, isoprenaline, is opposite in nature. Its predominant actions on beta receptor and very negligible action on the alpha receptor. What you can do is write alpha receptor and write which drug has got maximal action on alpha and which drug then and which drug then. So as far as alpha receptor is concerned, epinephrine has got the highest action, less than epinephrine is norepinephrine, and the least is isoprenaline. A point to remember, isoprenaline has negligible alpha actions because it's coming at the end. Whereas if you come to beta receptors, isoprenaline is very potent on the beta receptors. Next in order is epinephrine, and the last one is norepinephrine. To highlight, norepinephrine has negligible beta receptor effects or beta receptor actions. Let's concentrate now on epinephrine, which stimulates alpha as well as beta receptors. This is mostly used by subcutaneous route of administration, although you can give it by intramuscular or intravenous routes of administration, keeping in mind that it's going to lead to cardiac stimulation, and in the muscle it can lead to vasoconstriction. You need to dilute the drug adequately, and you also need to give it slowly to avoid this cardiac stimulation if you want to inject it by intravenous route of administration. What are the important actions? It's going to stimulate the heart, the beta-1 receptors, leading to positive ionotropic, chronotropic, dromotropic and backmotropic effects. Is going to lead to increase in the cardiac output. And what I want you to remember as pharmacology students is adrenaline increases oxygen consumption. That's very important. And whenever the heart is suffering from a compromise, like the heart is failing, it's a heart in heart failure, or it's a heart which is going into infarction, never think of epinephrine, because epinephrine increases the oxygen consumption and is going to worsen the cardiac failure. The second effect is on the bronchus. It stimulates the beta-2 receptors in the bronchus to produce bronchodilation. Thirdly, it acts as physiological antagonist of histamine. I would remind you of non-receptor antagonism, what we discussed in general pharmacology, where the two drugs are acting on different receptors but on a same physiological system. You call it physiological antagonist. Histamine is going to decrease the blood pressure and produce bronchospasm. Epinephrine is going to increase the blood pressure and is going to produce bronchodilation. This is how you get the physiological antagonism with histamine. Next, epinephrine is definitely going to increase the blood sugar by acting on the beta-2 receptors in the liver, and because it also acts on the alpha receptor, is going to constrict the small blood vessels which contain the alpha-1 receptor. Let's have a look at the effects of epinephrine on blood pressure. It acts on both the receptors, alpha. So if it acts on alpha, it constricts the peripheral blood vessels. This is going to lead to increase in the blood pressure. The effect on beta receptors is mainly going to be on the skeletal muscle blood vessels, which constitute almost 30% of the blood vessels of human body. And because this receptor is beta-2 and it's an inhibitory receptor, is going to lead to vasodilation, and this is going to lead to fall in blood pressure. So epinephrine is going to increase the blood pressure and is also going to decrease the blood pressure. It would have been simple if both these effects would have happened at the same point in time. But look at what happens. The alpha receptors are impatient. They start early, and you know, one who starts early finishes early. So alpha receptors start early and finish early, whereas the beta receptors start late and they finish late. Naturally, alpha and beta receptors are not acting at the same time. So first alpha receptors are acting, and while the alpha are acting and they're increasing the blood pressure, the heart is in systole, and this is why we say epinephrine increases the systolic blood pressure. By the time the action of the alpha receptor is over, the beta receptor comes into play, and the effect on the beta receptor is going to be fall in the blood pressure, and at this time the heart is in the diastole, so we say epinephrine decreases the diastolic blood pressure, which means epinephrine produces a biphasic response. It produces increase as well as decrease in the blood pressure. First it will be increase, which will be increase of systolic blood pressure due to alpha action, and then decrease due to the beta action, that will be the diastolic blood pressure. Look at the picture, biphasic response, and follow the cursor which I am showing. This is the action of the alpha receptor. The blood pressure goes on increasing, and by the time the alpha action is over, the beta receptors come into play and they produce a fall in the blood pressure. So that's what is called as biphasic response of epinephrine. They might ask you, which of the following drugs produces biphasic response on the blood pressure. That will be always epinephrine. Now, if you give an alpha blocking drug before giving epinephrine, what would happen? Let's see. I have added an alpha blocking drug, then I am giving epinephrine. So look at this particular graph. When I am blocking the alpha receptor, I am not going to see anything about the alpha receptors. The alpha effect is going to be masked, and what you are going to finally see is only the beta effect. And if someone tells that this is the graph of blood pressure of epinephrine, you're likely to get surprised, because epinephrine is a sympathetic drug, and this graph would tell that epinephrine decreases the blood pressure. This is happening because we have blocked the alpha receptor, so the alpha action is masked and you only see the beta action. This beta action is fall in the blood pressure. So this is how the graph looks if you have given pre-treatment with an alpha blocker. This graph is reversing the biphasic response of epinephrine, and that's why this is called Dale's vasomotor reversal. So instead of asking you the effect of epinephrine on blood pressure, someone could also ask you which is the drug that produces Dale's vasomotor reversal. With which drug you can see this phenomenon, and that's always epinephrine and epinephrine. That's Dale's vasomotor reversal. Now, could we use epinephrine for hypotensive shock? Will it be a very useful drug? It increases the systolic but decreases the diastolic, so there is no effective increase in the mean arterial pressure. So epinephrine is not a very ideal drug to treat the hypotensive shock. Whereas norepinephrine acts only on alpha receptor, there is no action on beta, and you can only get the increase in the blood pressure effectively. So norepinephrine is better as far as hypotensive shock is concerned. There is third drug to compare, and that's dopamine. This dopamine increases the blood pressure. In addition, it acts on the D1 receptors in the kidneys to produce vasodilation. The advantage is the blood supply, the blood flow to the kidneys is maintained, and it is helpful to prevent the renal failure. So dopamine is the most preferred drug in condition of cardiogenic shock. Let's have a look at this. Norepinephrine, there will be only increase in the blood pressure. There is no fall due to diastolic because it has got negligible action on beta. Isoprenaline has got predominant action on beta receptors, no action on alpha, negligible action on alpha. So you see only fall in the blood pressure. That's about isoprenaline. Let's come to the uses, where we are going to use epinephrine. Number one, a very important drug because it's physiological antagonist of histamine in the management of acute anaphylactic shock. Next, when a patient comes with an acute attack of bronchial asthma, you can inject epinephrine by subcutaneous route of administration. When the heart has stopped, that's cardiac arrest, you can resuscitate the heart with the help of epinephrine. You can give it intravenous or subcutaneous or sometimes by intracardiac route of administration. And 0.2 to 0.3 ml of 1:1000 epinephrine hydrochloride is commonly used for all these purposes. The next use of epinephrine is very important because this is the most common use where epinephrine comes in clinical practice. Epinephrine and a local anesthetic lidocaine are combined. Epinephrine produces vasoconstriction and prolongs the duration of action of local anesthesia, and that's a very important use of epinephrine. Lastly, because it acts on the alpha receptors and produces vasoconstriction, is going to stop the minor bleeding from the smaller blood vessels. A very common bleeding is epistaxis, is the nasal bleed, as well as the bleeding that happens during tooth extraction. So these five become very important uses of epinephrine. It's a very useful drug in conditions of emergency, and the emergency tray always contains epinephrine. I would like to add few comments on the epinephrine local anesthetic combination because this is very commonly used. There is vasoconstriction of small blood vessels due to alpha receptor stimulation by norepinephrine. This decreases the rate of entry of local anesthetic, and the local anesthetic keeps on entering over a long period of time, leading to a prolonged action or sustained action. So if you desire to use local anesthesia for a surgery for which you feel is going to take a little longer time, it's better to inject local anesthetic with epinephrine. You're likely to get a long duration of the local anesthesia. There is one more advantage of this, is the amount of systemic absorption of local anesthetic is going to be minimized. The chances of systemic adverse effects, A/E, is adverse effects of local anesthetic, is going to be minimized, and the bleeding also will be minimized. So many advantages with epinephrine local anesthetic combination. Are there any contraindications? Yes. We know there are some sites supplied with end arteries and there is no anastomotic circulation because epinephrine is going to produce vasoconstriction. The blood supply to these areas is going to be compromised, and if there is no anastomotic solution, the blood supply to these areas is going to be compromised. And if there is no anastomotic circulation, then these particular tissues are going to suffer from necrosis. I'm giving you an example of the sites supplied with end arteries is the fingertips, toe tips, and the male sex organs, which become very important because there's a very important operation carried out, what is called circumcision. For this particular operation, you're never supposed to inject epinephrine with local anesthesia. Then the patients who are suffering from severe hypertension, history of angina, myocardial infarction, and heart failure, congestive heart failure, we are going to avoid this particular combination to avoid the risk of epinephrine going into the systemic circulation and damaging the heart. Next, we move on to isoprenaline, which is a beta stimulant, has negligible alpha action, acts on beta 1 as well as beta 2. So it's a non-selective drug, and it could be used for cardiac arrest and Stokes-Adams syndrome, which are the cardiac conditions, as well as bronchial asthma by sublingual route of administration given for acute attack. But please remember, isoprenaline can produce cardiac stimulation because it's not very selective. That's the beta 1 receptor action. After catecholamines, we'll have a look at noncatecholamines. And a very important drug in noncatecholamines is ephedrine. This ephedrine is a mixed action agonist. It's got indirect action of increasing the release of the neurotransmitter, as well as it's got its own agonistic action on alpha and beta receptors. But as we saw in the beginning, the noncatecholamines can cross the blood-brain barrier and they start producing the central nervous system. So ephedrine very importantly produces CNS stimulation, which can manifest as an adverse effect of lack of sleep. But the good things about ephedrine is it is a nasal decongestant, it's a bronchodilator useful in bronchial asthma, and it could be combined with diazepam for prevention of nocturnal attack. This diazepam is going to prevent the lack of sleep, which is an adverse effect of ephedrine. Ephedrine also is an active mydriatic because it acts on the alpha receptor. So if you put it in the eye, it could produce the mydriasis. And as we discussed earlier, please don't forget tachyphylaxis. A very important example is ephedrine. The second important non-catecholamine is amphetamine. And very important to remember is it produces CNS stimulation, it decreases appetite, it is a nasal decongestant, and it is also a mydriatic. Amphetamine is useful in the management of narcolepsy because it's going to inhibit that abnormal sleep. It's going to be useful in the management of obesity and is useful in the management of attention deficit hyperactivity disorder. The use of amphetamine in attention hyperactivity disorder is not clear. What's the mechanism behind this particular use is not clear, and this is why it's called paradoxical use of amphetamine in the management of ADHD. Important to remember, amphetamine should not be given in the evening. If you give it in the evening, it's going to produce lack of sleep and it's going to interfere with the normal sleep of the patient. So the last dose of amphetamine should not be given after 4 or 5 o'clock in the evening to avoid the interference with the normal sleep. Amphetamine produces psychic as well as doubtful physical dependence, and it also leads to decrease in the performance. Let's now go to the selective agonist, because the drugs what we discussed until now were acting on the alpha as well as beta receptors, and we were getting many adverse effects due to those other receptor sites. There are selective agonists. Number one, acting on the central alpha-2 receptors. We have clonidine and methyl dopa. They are useful in hypertension because the central alpha-2 presynaptic receptor is inhibitory in nature and is going to lead to fall in the sympathetic outflow. The next one is phenylephrine, which is an alpha agonist and has got more alpha-1 action as compared to alpha-2. It's useful as nasal decongestant. It's also useful as mydriatic and could be useful in glaucoma. The newer alpha-2 agonists which are useful in glaucoma are apraclonidine and brimonidine. The vasopressors act selectively on the alpha-1 receptor and they produce vasoconstriction and are useful to increase the blood pressure. So vasopressors means increasing the blood pressure. And we have 3 M's here, that's methoxamine, metaraminol and mephenteramine, and the last one is phenylephrine. We have nasal decongestants which are going to stimulate the alpha-1 receptors of the smaller blood vessels and lead to the effect of decongestion. We have pseudoephedrine, xylometazoline, oxymetazoline, nafazoline as well as phenylephrine. Next we move on to the selective beta agonist. There's a very important selective beta-2 agonist, that's salbutamol, useful in bronchial asthma, used by the route of inhalation as well as the oral route of administration. You have salbutamol, which is also called albuterol. You have terbutaline, which has got a little longer duration of action. Another example is isoetherine, and you have salmeterol and formoterol. All these are also selective beta-2 agonists, but the last two, salmeterol and formoterol, also produce a long duration of action. There are uterine relaxants, which are also called tocolytics. They are going to act on the beta-2 receptor in the uterus, and because this receptor is inhibitory in nature, is going to be useful as uterine relaxant. Examples of the drugs are isoxaprine, nilidrine and ritotrine, out of which ritotrine is most commonly used, and they'll be useful in the management of threatened abortion, dysmenorrhea and premature labor. Let me mention one selective beta-1 agonist, that's dobutamine, which is very useful in the management of heart failure, because this drug increases the force of contraction of the heart, so heart failure could be helped with. It increases the cardiac output, but it does not increase the heart rate. It's very important not to increase the heart rate and just to increase the force of contraction. That's the novelty about dobutamine. So that's a selective beta-1 agonist. Sometimes fenfluramine can be used as an anorexiant, and it's a selective agonist. We could just go to the revision of the receptor sites so that it will be definitive idea in your mind. Alpha-1 receptor is present in the peripheral blood vessels, leading to vasoconstriction and increase in the blood pressure. Alpha-1 receptor is present in the radial muscle of iris, which is going to produce active mydriasis. Alpha-2 receptor, the most important site to remember, is the presynaptic alpha-2 receptor in the central nervous system. This is going to lead to decrease in the peripheral sympathetic outflow. So there will be decreased norepinephrine release, there will be decreased sympathetic outflow, and it also leads to decrease in the insulin release. Whereas coming to the beta receptors, most important is beta-1 receptor in the heart, which leads to increase the rate, force of contraction and the oxygen consumption. The beta-1 receptor in the kidney, when gets stimulated, stimulates the secretion of renin from the juxtagranular cells of the kidneys. And the beta-2 receptor, important sites are bronchus, leading to bronchodilation, skeletal muscle blood vessels, leading to vasodilation, liver, leading to glycogenolysis, and uterus, leading to relaxation. So that's all about the important adrenergic agonists and the adrenergic receptor sites. Thank you very much.